With them. So without further ado, I'd like to invite Stephen Posnack. He's the Executive Director for ONC's Office of Technology to the stage, as well as Elise Sweeney Anthony. She is the Executive Director for ONC's Office of Policy. All right. Perfect. All right. So as I mentioned, the patient records and access to it, a major milestone in that area occurred in February with the announcement of the new rules. So we wanted to make sure and kick off our event today to talk about the importance there from a health IT perspective and talk a little bit about it. So let's get right into it. Let's talk a little bit. It almost seems like an obvious concept that if you're a patient, you would have access to your health records as much as possible, be able to move it from provider to provider and see it. But this is new, and this has really caused a major change within this world, especially when data is so important to so many technology companies and individuals. So if you could just kick off by talking a little bit about the importance of it and what that really meant to the industry.
Absolutely. So thank you so much for the opportunity to be here. We love talking about our rule. We worked very hard on it, and we're excited that it's out for public comment now. So the Office of the National Coordinator for Health IT, we focus on thinking about health IT, where it is now and where it needs to go. Congress passed the 21st Century Cures Act at the end of 2016, and one of the titles in that act was focused on health information technology, in particular, access, exchange, and use of a health information technology. So there's a couple of things that we really focus on in the rule around that, and one is around addressing the flow of information. So ensuring that as much as possible, information is flowing where it needs to go for the benefit of the provider and the patients that they serve. And we've seen over time that there are some impediments to that. Some of those are business practices in terms of the hoarding or keeping of information within systems that prevents information from going where it needs to go. So in terms of our certification program, we are proposing to update it to include conditions and maintenance of certification requirements. Now, in the past, we focused very much on the technical aspects.
The conditions.
Okay, there we go. Thank you. So we focused on the technical aspects of the program in terms of what are the functionalities that you need to have to be certified by ONC under our program. But what Congress has asked us to do is to also think about the behaviors that impede the flow of information. So Steve will talk a little bit more about that. I also want to talk about information blocking, which I think is the next slide. Mm-hmm. So information blocking is along those same lines of access, exchange, and use of health information. And what Congress asked us to do is to think about what are the exceptions. So Congress lays out a definition for electronic health information. That's the information you'd have to move. It lays out actors. So those are the folks who are going to be subject to the potentially $1 million fines if you are a health information network, a health information exchange, or a developer of certified health IT. If you are a provider, then you could be subject to appropriate disincentives, and we seek comment on what those might be. But for those actors, you could be subject to information blocking if you're not moving information appropriately. But there may be situations where you not moving information makes sense as well. Now, while we want those situations to be narrow, and Congress has asked us to lay out specific exceptions for where you are reasonably and necessarily not sharing information, those are around things like privacy, security, preventing harm. There's a few that relate to charging fees. So there are situations where you should be able to charge fees to support innovation, but at the same time, not using those fees as a means to deter or a veil for not sharing information. We'll talk more about that, I'm sure. Mm-hmm. And then reasonable and non-discriminatory terms in terms of licensing of information. And then the daily upkeep in terms of if a system goes down, should you be considered an information blocker? Now, all of the exceptions we've laid out are really focused on a case-by-case analysis. But across the rule, whether it's information blocking or it's the conditions and maintenance of certification or provisions that we have in there to support patient access, our focus is really on supporting the effective and secure flow of electronic health information. And that's the undercurrent I think you see across the rule.
Okay, great. Steve, how about from where you sit in the IT section? I mean, like I was saying, data is so important right now. What does this mean for the larger industry right now in terms of this, with this new rule?
Yeah, absolutely. So as Elise mentioned, and I'll do a kind of quick recap of how we got to where we are today. we've been working on something that is related to incenting the industry to adopt electronic health records, as the video showed in the beginning, as well as making sure patients can get access to their data in electronic means. Many of you may be familiar with the HITECH Act, which was passed as part of the Recovery Act in 2009. That's where the large incentives were made available for electronic health record adoption. I'm trying to not use any of the acronyms that we currently use. That led to significant increases in EHR adoption. Over 90% of hospitals now have electronic health record systems. I think in the ambulatory space, it's greater than 75, 80% at this rate. So it's very successful from an adoption perspective. In 2012, we first included rules that incented the availability of what would be called in lay terms patient portals. So if you go to the doctor today and you can access your health information online through your web browser, that was part of the work that we did early in 2012 to start to get the healthcare industry to make patient data available to patients online. Now all of us have a lot of portals. And that gets to the technology area where often healthcare has a technique to do things unique to healthcare. And we are looking to other industries, 21st century, as the ACSO notes, technology implementations. And so part of the law includes a reference that health IT developers now need to make application programming interfaces, APIs, that are pretty prevalent in all other industries for software interactions available as part of one of their legal requirements. And that's one of the things that the new regulations that we've proposed touch on. So there's a law that actually says APIs in it. If you're a technologist, it's kind of remarkable. And our work today is to make sure that the guardrails and guidelines around the access and exchange and use of health information through those APIs is done appropriately, securely, via standards-based APIs, and the statute references that they can be used without special effort. So in other industries, that usually happens in a commercial kind of competitive setting. By virtue of the statute, we have this new, unique, specific requirement to make APIs available that can be used without special effort. And so a lot of our proposals tackle what that takes. The point in case that we often reference in terms of innovation and competition is for those of you that have iPhones, you may have noticed in the past year or so that Apple has a health records app. That uses the standards work that we've done through industry, standards organization called Health Level 7, uses another standard called FHIR, which HL7 helps to FHIR, sorry, new acronym for some of you maybe. And that's the opportunity for API-based data exchange in a healthcare context. And so a lot of that is now rolling out into the industry, but there's much more work to be done.
So a big reason we wanted to introduce this rule and invite, I should say, the Office of National Coordinator here is you guys go across, there's so many healthcare agencies now, and this is such an important rule for all of them. Could you talk a little bit about maybe the challenge that comes along with that? We have a lot of different agencies represented today. What's the importance of being able to do that across each one and being on the same page there?
Yeah, so I would refer to it more as an opportunity. It's a great opportunity for us to think about interoperability across the federal sphere. In our title, we have coordinator, Office of the National Coordinator for Health IT, and we take that responsibility very seriously. We work across all federal agencies, whether it's CMS or HRSA or CDC. There's many situations where we try to coordinate and serve the needs of the agency as well. Under one of our previous federal advisory committees, we worked with CDC to identify the appropriate pregnancy standards, which were critical, in terms of Zika and providers being able to address Zika. With CDC, we work with them, with CMS, we work with them hand in hand on their programs like Promoting Interoperability Program, or some of their work with CMMI, right, their innovation models, thinking about how health IT can support their needs and how to ensure that there's interoperability associated with that. So as Steve mentioned, with some of the work with Apple being able to connect patients to their health information, we worked with CMS back in 2015 in terms of thinking through APIs. And at that time, it was more of a functional level. Now what we're proposing in our rule is the actual standard, the FHIR standard. But at the time, we proposed a functional kind of box in terms of if your API does these things, then you can be certified. CMS also had in their rule a complementary provision that affected the behavior of providers, which is now coming into fruition transition. So if there's any providers here, you're aware of that in terms of this being the first year. But from the CMS side, they looked at the providers and providers providing the opportunity for patients to access their information through API. It used to be view, download, transmit. Now it's view, download, transmit, and API. So those types of innovations and developments over time can't happen just through ONC. So I think we're very privileged to be able to work with so many federal partners who believe and support interoperability.
Okay. Steve, you mentioned how Apple has really taken to this, and you guys worked together with that. We have a lot of members of the industry here as well. What's the importance of having being able to translate that and having your team be able to work with companies like Apple and some of the other ones out here that are with us today?
Yeah, it's absolutely essential for us to keep fresh in terms of what's going on from a technology perspective. Our office is really at the cross-section, as Elise was just giving you a flavor of the many federal agencies and missions that we intersect with from a health IT perspective. I try not to use cliches too early in the morning, but it's about the data. And in health IT now, you really can't do anything meaningful and impactful without data. And a lot of the work that we do now is figuring out how to translate the data that's accessible to healthcare providers, population analytics companies, patients, and translating that into impact. And so as we work with innovative companies that are trying to get access or enable access to data, that's a lot of the feedback. And some of the other roles that we do as your federal civil servants here, the superpowers that we have are to work within other federal agencies and translate some of the different mission and activities that they're working on into the health IT space or vice versa. So when we work with, say for instance, the HHS Office for Civil Rights, so for those of you that are familiar with HIPAA, there are a lot of intersecting privacy and security related aspects with respect to health data, new technologies, HIPAA privacy and security misunderstandings, and so that's a lot of behind the scenes work that we do to help clear out some of the misunderstandings from a federal policy and health IT perspective.
Well, one of the reasons we chose to have, start this panel, have this kick off the morning, was we really feel like it really has a lot of impact on the next 3 panels that we're going to have later today, whether it be precision medicine, the different programs that are tackling the opioid epidemic, and then digital services for veterans healthcare. It's really interesting. You talk about data, and that's a theme that keeps happening over and over. What has been the reaction to the rule so far? So this was announced in February, got quite a bit of attention at HIMSS when this was first rolled out. What is the reaction that you've gotten so far from both the government agencies as well as the industry?
Well, I can start. I think, first I'll do my public service announcement to please comment on the rule. So the comments are due May 3rd. And we really value, I think, diverse perspectives. So whether it's a patient, provider, whether you are a consultant, all of those commentary, those viewpoints help us to put together a rule that will really work on the ground. And that's something I'm always very committed to, is not developing policy in a bubble, as I like to say, but really thinking about how it's going to operate on the ground. In terms of feedback, I think we've been getting some good feedback in terms of how we've scoped out information blocking, for example, and addressing a lot of the areas that we've heard over time. Before the rule was released, we had many stakeholder meetings, including joint meetings with the Office of the Inspector General, which will be responsible for enforcing what we call 4004, which is the information blocking section. So we heard a lot from the community, and not just providers, but just whether it's HIE, Health Information Exchanges, no acronyms, Health Information Network.
I challenged them today.
Just across the spectrum. But we heard that information blocking takes many different forms, and that once you address one type, another variation comes up. So what we tried to do in our rule was to think from a case-by-case analysis, right? Looking at having OIG have the ability to look from a case-by-case analysis at what needs to happen, whether information blocking has occurred. And I think we've gotten some positive feedback on that. We also have our Health Information Technology Advisory Committee looking at the rule. And it's an amazing cross-section of stakeholders from across the community who volunteer their time to really help us think through some of the components in the rule. I think we've been getting great feedback from them as well, including that there may be some areas where we need to adjust, and that's okay. Every time we do a rule, we understand that we want to know where we've hit the right points, where we've missed the mark, so that we can put together a final rule that really works for the community. And I think the last thing where we've really got some great feedback on is some of the provisions we have around patient access. access. And that's a cornerstone throughout the rule, throughout our work at ONC. So for example, in the rule, we say that as part of the information blocking, the 4004 section, that a patient has the right to get their data electronically. So if a patient requests their information electronically, and they're requesting the electronic health information as we define it in that section, that should be at no cost. And we've gotten a lot of great feedback on that provision. We've also included a provision in our certification program that would require developers to make information available more easily to patients at their request through the EHR, as well as to help providers be able to switch EHRs when they feel appropriate. And I think provisions like that have gotten some great feedback. But again, we're open to all feedback, positive and negative, because that helps us to get to the right space.
Okay. Steve, how about you?
Yeah, I mean, part of the reason why we're here doing the job that we do, and you're here, listening to us talk about the job that we do, is because when there's the right mix of technology and policy and imagination, we can make a lot of impact. And so the work that we're doing through the proposed rules that we have is really focused on introducing a new opportunity for competition in the health IT space, in healthcare in general. So part of that is getting patients access to their health information so that they can shop for care. They can be in control of their own health data through the apps and other services that they choose. And then equally, by making data more accessible within the clinical ecosystem, allowing healthcare providers to also participate in a more market-based economy with better access to other types of apps and services that they may not otherwise have available today. And so just to give you a little bit of an example related to the API, since we've used that acronym already at this point, proposals that we did, part of the Cures Act, again, as I mentioned, requires that they be available without special effort. So when we looked at what could constitute special effort, there were really three categories of things. One was around transparency. It's hard to get access to documentation presently in healthcare for what would likely be proprietary interfaces. And so you need to knock on all the right doors, you need to know the right companies in order to get access to that. So what we have around our proposals is publicly accessible documentation, terms and conditions, et cetera, and the like. And then secondarily, as Elise mentioned, there's this intersection in this term of art that we use quite often, which is called information blocking, that pricing and other cost practices can impede the flow of your health information when it comes to getting access to data. And so we include certain guidelines around price aspects of access to APIs and the like. And then the third is around anti-competitive practices that will otherwise be those business kind of impediments. One example, as Elise mentioned, is around reasonable and non-discriminatory terms. And so we've seen examples where a health IT developer wouldn't let a customer connect to their system because that other app or service that the healthcare provider wanted to use would compete with another service that health IT developer had. And so keeping people out of the market because they're a competitor is one of those areas where we looked at both in information blocking related concerns as well as the broader competitive landscape that we were trying to include proposals to address.
Okay.
And I was just going to add to one thing I would say on the information blocking side. As Steve said, we try to think about the the importance of information moving not blocking information because of competitive reasons, right? So in the information blocking section, which I'm sure everyone's going to read, you'll see words like objective, verifiable, reasonable, non-discriminatory, words that allow for there to be kind of increased flow of information, not based upon whether, if I'm a hospital, whether you have privileges at my facility, right? We want to make sure the information flows where the patient needs it in a secure way, and that's really the underpinning of the information blocking section as well.
Okay. So I have a couple more questions for these, but we wanted to save questions for the audience as well. So Chris, if you could get one of the microphones ready, we'll just ask another question here, and then we'll open it up to the audience here. And here's a quick reminder too. Again, I'll emphasize the hashtag CXO Tech Forum. We want to really encourage that conversation throughout the morning today. So you kind of mentioned the fact that this is going to mature. This is going to evolve, just like any rules. I mean, technology is changing so fast. It's going to really be the pressure there to make sure that the rules fix with it. So how do you guys expect the rollout to go forward with this? And then again, how are the plans to adapt to keep up with the pace of technology?
Go ahead. By all means.
So I think when we develop rules and when we're looking at, let's say, the conditions and the maintenance of certification provisions, we think about providing the right foundation so that there's a standards-based environment in which health information moves, electronic health information moves, which supports interoperability, which supports the ability of patient and providers to have the information they need at the time of care. But we also try to allow for innovation to occur over time. So even as we think about identification of standards, we have a new provision in the rule that focuses on standards updates, and I won't steal Steve's thunder on that, but that's one way that we try to address kind of the coming times. The other thing that we do in the rule for many of the provisions, things like real-world testing, the API provisions that we would be requiring developers to have, those would be coming into place over time. So once the rule is finalized, right, then there's an effective date for when the rule takes place. And we make sure that there's 2 years time is what we have proposed, but folks can comment, 2 years time to allow for developers to develop the technology that they would need and then ultimately roll it down to the providers who would actually use it. So allowing that time span for folks to understand what they're being required to do, implement it, and then roll it out is critical. So we try to account for that within the rule. And then over time, we look forward to hearing how standards innovate, develop more over time, and we would consider that on an ongoing basis.
Okay.
Yeah, Elise highlighted what I like to call the regulator's dilemma. And in some respects for us, as a technology agency that is a regulatory body as well, at least half of our mission, so to speak, we are always in this delicate balance where we want the industry to keep moving as fast as possible and make updates. And then equally, we have a statutory mandate to run what's called the Health IT Certification Program. And you need to have a level of consistency and a baseline that is expected among the entire industry so that app developers and other services, know where to kind of, point their strategy and what technology requirements they expect to be able to interact with. So as Elise mentioned, we have, some timelines that we include an incremental rollout of things, and then we have also proposed, with some of our new authority under the 21st Century Cures Act, a process to help update the standards that we reference in regulation, which is a bit of a challenging process for us as a regulatory agency. To help recognize as new standards get adopted that we can find new ways to have the national coordinator, who's in charge of our office, approve updated versions in an incremental basis of those standards. And so it's a little bit unique, whereas in some cases, a federal agency may lock in a particular standard, and then that will be it until they regulate 10 years later. We're looking for a more incremental, kind of two-step with the industry as we go forward.
Okay. All right. Does anyone have any questions? Chris has it. Oh, right back here.
Hi, good morning, and thank you for Government ICL for this great event and the panel. My question is this: the integration is very good. However, there's a situation with the veterans. When the veterans go to a VA hospital, he creates his account and he has accessibility. However, if that particular veteran goes with the family to Florida or California and he needs a medical attention and he goes to the local VA hospital, that VA hospital doesn't have any access to his medical records immediately to see for what has been seeing him in Washington, D.C. So across the nation, there is no integration from the VA to have a mutual access for that particular veteran to see his records and what disease has been taken care of it. For instance, even here in D.C., if the individual goes to Bethesda Hospital, Bethesda Hospital doesn't have, Walter Reed Hospital doesn't have any access to the VA hospital of his medical records. So the individual cannot just go carry a computer with him, have the access to his file, say, oh, here it is. Or let me print it out so I can scan it so I can send it to you. So the integration for the veterans is very, very important and it hasn't taken place.
Okay.
Thank you.
So there's the question, is that a common question, of just how the VA or in the DoD can work better together?
I think they should.
Okay.
It hasn't happened.
Sure. And that's actually a panel that we're going to get to at the very end with Dr. Evans and Charles Worthington, so we can address that as well. That is a very concern. As a veteran myself, I experienced that as well when I got out of the Air Force and then moved on to the VA. But I think that the question really goes to, DoD is one of the biggest collections of health records that are out there. It might be a good example, if you guys could talk to, of how that might help the effort that's going on between the DoD and VA to go to that electronic health records possibility and making that easier, making that transition easier for so many of America's veterans.
Yeah, I mean, certainly the case that he highlights is something that's not unique to VA, right? That's the experience that a lot of Americans have today with respect to their healthcare system experience. I like to, being relatively healthy, I live the healthcare ecosystem through my kids. I have that just when I go to the pediatrician versus the urgent care, which happens quite frequently. Especially with this extended flu season, right? So, being able to, one area that we are trying to address this with, and I know VA is as well, is making sure that we all have the data that we think is important for ourselves and our family in our own control, so that we can be the ones that can share that information if it's not accessible to our clinicians. Equally part of our mission, and the dirty work that I do every day in the office, is making sure the underlying interoperability requirements are in place so that when it comes to, from the technical perspective, the systems are able to exchange data, be it VA to, DOD, VA to other VA, VA to the other, external party, partners that they may have in exchanging health information. There's often the ATM gets referenced, in terms of why healthcare can't just exchange data, as quickly as we can get, money out of any ATM from a different bank. Healthcare is much more complicated, just in terms of the amount of information that's relevant to your clinical care, what needs to be protected at different levels in some cases based on federal statute that certain federal agencies have to deal with, equally state law, and so there's a lot of other distinguishing characteristics. But point very well made in terms of this is the current state that we live in today and why we're really passionate about trying to change that.
Absolutely. All right, any other questions? Nope, right there to the right, Chris? Or Tony? Yep. Perfect.
Just to state what he said a little bit stronger, so, the rules obviously apply for commercial. Will those same rules be applicable across the federal space, and how? So I'm thinking back to like meaningful use, for instance, was a great push forward from ONC, and it never really was adopted within VA, for instance. So how will these rules apply to VA directly?
So I think, we across the field, we always work with our federal partners to identify and to address access exchange and use of electronic health information. So I think it depends on kind of what aspect of the program. There's one aspect that's related to certified health IT developers, and then in some cases, where it's a health care provider under the information blocking section. For example, Indian Health Service is one of the entities that are captured. So we always work across our federal agencies to identify what opportunities there are for us to work together to make sure that information blocking is not happening, to support the flow of electronic health information. And I know that that's something that we're going to continue to do as we move forward. In addition, when we are putting together rules, we always work internally across federal agencies so that they have an idea, they see what we're thinking of, what we're proposing before that even goes out of the door.
Okay.
Yeah, I mean, the one thing I would add just that Elise just touched on too, the other timeline difference is, 2010, 2011, VA was still on Vista. Now they've moved, are moving towards Cerner, which is an organization and a health IT product that we regulate. And so there'll be a little bit of a different, I think, mix and balance in terms of the compliance obligations, what they're going to get out of the product that they've acquired, and the regulatory intersection that we have.
Okay. Well, I think that's the time we have to kick off our fireside chat here.
Yes.
Thank you to you both, Steve and Elise, for joining us and talking about this very important new rule that's being addressed across the government right now. So can I get a round of applause for the two of them? Thank you.